Up next, James Cheseboro is joined by Dr. Karen Stout, Director of the Adult Congenital Heart Disease Program at the University of Washington in Seattle, to discuss newer antiarrhythmic and anticoagulant therapy and potential applications for adults with congenital heart disease.
Welcome to ACCEL.
Thank you very much.
Maybe you can tell us, starting out with the arrhythmia, what's the most frequent arrhythmias that you're seeing that you have to be treating?
So congenital heart disease is a huge array of different lesions as far as the underlying structural abnormalities. But what we tend to see is a substantial number of arrhythmias, either as a consequence of the underlying anatomy or of the surgical repairs that they've undergone to palliate or quote-unquote fix, they're not really fixed, congenital heart disease. So we tend to see a lot of atrial arrhythmias. Upwards of 40% of adult patients with congenital heart disease will have some sort of atrial arrhythmia. And it tends to be either atrial tachycardia or atrial flutter. Slightly unusual profile for atrial arrhythmias. Atrial fibrillation in this patient population, to this point, is less common than atrial tachycardia or atrial flutter. But it is a very common problem to have atrial arrhythmias. And what's difficult in the management is trying to decide where these patients fit in the stroke risk profile, because they weren't included in any of the CHAD scores or any of the underlying AFib and stroke data, because they do have underlying structural heart disease. And their structural heart disease puts them at a higher risk than somebody else, for example, who has AFib of a similar age, say 25, because they clearly have other reasons to have AFib, a flutter, or an atrial tachycardia that may put them at a higher stroke risk. So the other thing that's important about their physiology is that many of them do not tolerate atrial arrhythmias at all. Their hemodynamics can decline substantially, and in some physiology, for example, single ventricles who've been palliated with Fontan repair, they're at a particularly high thrombotic risk in their Fontan circulation and really don't tolerate atrial arrhythmias. So this is not a patient population where rate control ends up being a reasonable strategy the majority of the time. It's a sort of patient population where getting them back into sinus rhythm once they've had some sort of atrial arrhythmia becomes really important from a physiologic perspective in maintaining their hemodynamics and keeping them minimally symptomatic. So we've got a big burden to try and keep them out of arrhythmias that they're very prone to going into. So some of the newer medications, like dronedarone, seem very appealing. Young patients, not a lot of great antiarrhythmic options out there. We use a lot of sotalol in these patients. And then when we have to, amiodarone. But because they're young and in some cases have hepatic and renal dysfunction at baseline, these may not be the greatest drugs, or at least amiodarone, for the long-term side effects. So dronedarone, at least on the surface, certainly has some appeal, minimize side effects, perhaps more effective than some of the other options that we have. But at least thus far, it doesn't look like it's necessarily going to be a great drug for this patient population, as many of them have maybe a heart failure history, which would exclude them probably from having its used. So instead, we end up down the ablation route a lot.
That makes a lot of sense, trying to permanently prevent it from happening.
Right. These guys may not necessarily get the permanent relief that you would get in some other patients with more structurally normal hearts, but you can certainly get some sustained arrhythmia relief from taking folks to the EP lab and ablating their atrial tachycardia or atrial flutter. If you have that opportunity, it has to be done with very trained providers, but it's a good opportunity that we jump to in congenital heart disease perhaps more quickly than you might be accustomed to in more standard acquired adult heart disease.
That makes a lot of sense. And there is, of course, benefit in returning for a second ablation in many of these as well.
Right. Some of the abnormalities, Fontan's, for example, feels like you're playing whack-a-mole and just popping up a million different arrhythmic foci when they're in there in the EP lab. But others, you can have a really sustained, get rid of the atrial flutter, atrial tachycardia, and then even if it comes back 3 or 4 years later, be able to go back and have another ablative success.
So now maybe you can mention and talk about the anticoagulant therapies, antithrombotic, and I think we have to define what the underlying problem is. And is it a stasis-type thrombus, like with a PE, or is it a platelet-rich thrombus, which one has to try to prevent with maybe mechanical heart valves, and obviously AFib is more of a stasis thrombus too, so, and that will help us pick the right medication.
So again, getting back to the idea that these are not patients included in stroke or even PE trials, we're trying to extrapolate from other data. So there are a lot of indications to think about anticoagulating a patient with congenital heart disease, but bearing in mind that they tend to be young, they tend to be teens, 20s, 30s, 40s, and may or may not do well with warfarin. Think back to being in their 20s. Imagine trying to take warfarin and go through college and travel, but getting your blood drawn and having to be consistent on your diet, and alcohol consumption, all those things that a lot of young adults may encounter make warfarin oftentimes a really unappealing drug. So it's sort of a two-step process. The first is trying to assess their underlying thrombotic risk. If they have mechanical valves, that's easy. You just anticoagulate them based upon the guidelines. But other times it's harder. Between their atrial arrhythmias, their underlying structural abnormalities, perhaps they still have a residual right to left shunt. Perhaps they have a Fontan repair where there's a lot of stasis and thrombosis that can be of a concern in those patients. Something between 15 and 30% of them can have asymptomatic PEs, which are extraordinarily detrimental to their physiology. So there are a lot of different things you have to go through with each individual patient to try to decide if they need to be anticoagulated. And in some cases, the risks of warfarin in this patient group, or particularly individual patients, may offset your theoretic benefit. So the idea of these newer anticoagulants that don't require any lab draws and that don't interact with food, that patients don't have to be so thoughtful about their diet, they actually, once you've gotten to that threshold of feeling like you need to anticoagulate somebody, have a lot of appeal for this patient population from a purely practical perspective of getting rid of a lot of the issues that make warfarin such a difficult drug. And in reviewing what we know now about dabigatran, rivaroxaban, and apixaban, I think one of the more practical issues we're going to run into is that one adherence problem we already have with younger patients on warfarin is the inability to take once-a-day drugs. So asking them to take a twice-daily drug is not likely to be any more effective in anticoagulating them. And despite perhaps our best recommendations, they tend to be active, some of them anyway. I have many a patient on warfarin who, despite advice that they ought to think carefully about playing soccer or snowboarding or mountain biking, do it anyway. So although they may be at a lower risk for things like GI bleeds and intracranial hemorrhages that we're learning to worry about with the newer anticoagulants and their reversibility, they may be at a slightly higher prevalence of having issues of trauma that makes the idea of a reversing agent really, really potentially important in this patient population.
There's some that are reversible and some not, and I think dabigatran is one that's not.
Correct. And so far, as I'm sure has been discussed in other venues, the case reports of having substantial life-threatening or actually mortality-related bleeds from not being able to reverse the agent is starting to crop up in its real-world use. So in looking at this with no data, one way or the other, regarding the use of these drugs in congenital heart disease, I think the ones that are going to end up having the most appeal and potentially being quite applicable in our patient population are those that can be once daily dosed, and in some patients they can do the twice a day. For example, patients who are just traveling and therefore it's hard to check their INRs. So the once daily in particular, and in certain circumstances the twice daily, but I think having an available antidote, if you will, to the anticoagulant effect is going to be important for these patients as well. Once an antidote is available for dabigatran, that may actually make it a more appealing drug, but at the moment there's sort of a hesitation to take folks off something we know and put them on these newer drugs, but in certain circumstances they actually may be great drugs for some patients.
And the 10A inhibitors, though, are reversible potentially.
Yeah, I'm sort of looking at the 10A inhibitors with their reversibility using the plasma concentrates, at least the data that's out there for that, and the option for once daily dosing as probably being one of the medications that the congenital community may get into using relatively soon. Ongoing data on using it in mechanical valves, as that's acquired, that would certainly apply to our patient population as well, really well, in fact. So once we have some data on its effectiveness, any of their effectiveness in mechanical valves, I think we'll see a lot more adoption of using these medications in our patients.
Well, thank you very much for coming and discussing this complex topic involving antiarrhythmics, where it looks like ablation is a very good procedure in many of these individuals, and then choosing the proper drug for their underlying problem.
Complicated, no data, but we can try and extrapolate as best possible and make smart decisions for our patients.
Thank you for coming to ACCEL.
Thank you.